This is Dr. Sanjay Kumar Rai, Registered Medicine, Khulna Medical College Hospital. Today, I am going to talk on Pemphigus, the epidermal lesion. As you know, the dermis and epidermis, the layer of skin, and there are multiple layers in epidermis, and below the epidermis there is dermis. The pemphigus is the disease of epidermis, and pemphigoid, that is bullous pemphigoid, is the disease of dermis. So this is the basic. Now, what is pemphigus? Actually, pemphigus is an autoimmune disease. Here, the autoantibody like immunoglobulin G is found in the intercellular region of epidermis, and here the skin and mucosal involvement is common, and it is less common than bullous pemphigoid. And in pemphigus, the patients tend to be younger. The cause of pemphigus, it may be primary, that is unknown or autoimmune, and may be secondary due to drugs like penicillamine or captopril, and sometimes paraneoplastic, and this is called paraneoplastic pemphigus. What is the description of the lesion of pemphigus? The typical description of a pemphigus is they are flaccid. The lesions are flaccid, easily ruptured, multiple blister, filled with clear fluid, and burst with ulcer and crust formation, with erythematous or erythroid beige. What is Nikolsky sign? Actually, Nikolsky sign is lateral pressure on the affected skin or lateral pressure on the lateral margin of the lesion result in dislodgement of epidermal layers over the dermal layers, that is peeling out of the epidermal layer over the dermal layer when you give a lateral pressure, a shearing pressure on the lateral margin of the affected skin lesion. Okay, and this Nikolsky sign is used to differentiate the intraepidermal lesion from the subdermal lesion. In epidermal lesion, the peeling out of the skin will be found. On the other hand, in subdermal lesion, no peeling out of the epidermal layer will be found. Now, what is the cause or in which condition Nikolsky sign found positive? Number one, pemphigus, that is Pemphigus vulgaris and Pemphigus foliaceus, and number two, toxic epidermal necrolysis, and number three, Staphylococcus scald skin syndrome. Okay, now what are the types of pemphigus? Pemphigus are four types actually: the Pemphigus vulgaris, Pemphigus foliaceus, paraneoplastic pemphigus, what already I mentioned, and sometimes immunoglobulin A pemphigus. Actually, in pemphigus, there is immunoglobulin G is found in the intercellular space in the epidermis, but sometimes immunoglobulin A pemphigus may be. Now, what are the investigations to be done to confirm the diagnosis? At first, the routine investigation like CBC, ESR, urinary, blood glucose, serum creatinine, and liver function test, and skin biopsy is the investigation of choice to confirm the diagnosis. And the on-skin biopsy, that is histology, intraepidermal blistering, mind it, intraepidermal, not dermal. There is blistering, that is splitting of the epidermal layer. And acantholysis. What do you mean by acantholysis? Acantholysis is loss of coherence between the epidermal cells. Loss of coherence between the epidermal cells. The next skin biopsy finding will be intercellular deposition of immunoglobulin G and complement 3 by direct immunofluorescence, DIF. Now, what will be the treatment option? And number one is the general treatment, And then specific treatment. General treatment is bed rest with daily bathing as a patient suffers from foul smelling and crusting. So daily bathing should be recommended. Maintenance of fluid and electrolyte imbalance, maintenance of nutrition and antibiotic to prevent secondary infection, and sometimes blood transfusion may be needed. 1% silver sulfur diazine should be a topical preparation should be used over the lesions. And high dose systemic treatment option, the high dose prednisolone, the dose recommended dose is 0.5 to 1 milligram per kg body weight per day in 2 to 3 divided dose. And when remission occurs with no blister, the prednisolone should be tapered over the next 3 to 6 weeks. And sometimes, mind it, sometimes a long-term prednisolone may be needed. Another option, sometimes in severe case, intravenous methyl prednisolone 1 gram per day for 5 days. This is called pulse therapy. And azathioprine and cyclophosphamide, most commonly we use azathioprine is a steroid sparing agent. And other agent what may be considered in severe disease like methotrexate, cyclosporine, mycophenolate mofetil, that is MMF, and sometimes intravenous immunoglobulin, plasma exchange, and rituximab. And extracorporeal photophoresis may be used. The last the question should be, what is the prognosis of pemphigus? Prognosis is not good, that is bad, and recurrence is very common with high mortality. So this is all about pemphigus. The next video will be Nichols sign.